Welcome to the newly updated ANNA CKD modules that address nursing care of the patient with CKD in any setting. I am Leslie Dinwiddie, project leader for these modules. Today it is my privilege to introduce our author and presenter of the fourth module, Acute Kidney Injury, Causes, Treatments, and Outcomes. Dr. Alice Luer is Manager of Dialysis and CNA Float Pool at St. Peter's Health in Helena, Montana. She is also president of the ANNA Big Sky chapter and section editor for the acute care section of the ANNA core curriculum.
Hello, everyone. Well, welcome to Module 4. I hope you've been able to watch the other modules. They are an excellent resource for many people. So we realize that we share acute kidney injury patients with a lot of the chronic outpatient nurses. And we hope that this information on the acute care, acute kidney injury is helpful for you. Just let you know that these have been dedicated to our good friend, Sally Barrow Hudson. And once again, we are in CKD Module 4, which is the acute kidney injury causes, treatment, and outcome. As you go through this module, you'll learn more about acute kidney injury, or AKI. You'll learn the different classifications and causative factors of AKI and the treatment options for these different factors. These are the learning objectives for the module. So the prevalence of AKI seems to be on the rise, especially amongst hospitalized patients. It's really interesting. So I work at a small hospital-based dialysis unit at Helena, Montana, so we're definitely rural. And the amount of AKI I've seen lately has been kind of staggering. I think this is, I've been here for like 25 years, and I can say that we've had the largest concentration of AKI in the last like 6 months that I have ever seen. And the difference, that seems to be causing this is the lack of the increase in our aging population, increase in sepsis rate, and a increase in pre-existing cardiac and metabolic comorbidities that actually give rise to AKI or make it more prevalent for it. And we've seen kind of the whole gambit of different AKIs. We've seen rhabdo, we've seen, we actually had a young person decide to drink a bunch of antifreeze. So that certainly caused some acute kidney injury. And then we've seen like the medication-induced AKI. So it's been really interesting. So it's also important to know that AKI and chronic kidney disease are closely intertwined. The presence of CKD increases the patient risk for developing AKI tenfold. So quite often we'll see patients with underlying CKD and having an AKI episode on top of that. And we've actually had a fair number of those here lately too. Luckily, we've been able to get them through the AKI and they go back to kind of their chronic stage 4 or so, and are doing okay without dialysis. Both AKI and CKD, as we know, are closely related to any sort of cardiac problem and or disease. And in the presence of cardiac disease, the increased chance of AKI and CKD is also increased. Really becomes kind of a vicious circle. Patients with CKD should be monitored for episodes of AKI, and patients recovering from AKI should be monitored for progression of CKD into stage 5 kidney failure. The single symptoms of AKI is the abrupt decline in glomerular filtration rate. You'll see an increase in metabolic waste products in the blood. Certainly are looking at creatinine and BUN, and they will become elevated. Whereas CKD is not reversible, AKI usually is. And we're going to discuss the guidelines developed for the diagnosis and staging criteria for AKI. Once again, increasing serum creatinine and decreasing urine output help determine the presence and severity of AKI. The 4 phases of AKI include onset, oliguria, anuria, diuresis, and recovery of function. During the onset phase, either pre-intrinsic or post-kidney damage occurs. And we'll discuss the different types of pre-intrinsic and post a little bit later. The duration of this phase can be hours or days and can be caused by a multitude of factors. And we'll go over some of those factors that can cause that onset. During the oliguric age or anuric phase, the kidney tubules have decreased ability to filter the waste products, so you just won't get any sort of urine output at all. There are times when there is no discernible decrease in urine output, though, so you have to remember that. Oliguric means slightly decreased urine output, but they can be non-oliguric and still have AKI. The duration of the oliguric and anuric phases can be anywhere from 8 to 14 days, and it really depends on what is causing the AKI. During the diuretic phase, urine output increases as the tubules are being healed. I mean, they just become a sieve and everything goes through them. That phase can last 7 to 14 days, and the urine output can lead to electrolyte depletion. So you need to be watching these people in that diuretic phase and making sure that their electrolytes stay okay and that they don't get dehydrated. The recovery phase usually is the tubules are resolving, they're getting healthier, and then you can get that recovery. And that can last several months to years. And during recovery, quite often the person doesn't need any sort of renal replacement therapy, but they do definitely need to be monitored to make sure that their electrolytes and volume statuses are fine, because they should be returning to the patient's baseline. Different staging criteria for AKI are out there. Probably many of you have heard of the rifle. We also have AKIN and KDIGO. These staging criteria determine the presence of acute kidney injuries and have been developed by these 3 different organizations over the past 2 decades. The Acute Kidney Disease Quality Initiative, ADQI, was what went into the rifle guidelines, and these were revised in 2007 by the Acute Kidney Injury Network. And then KDIGO came along in 2012 and revised them a little bit more. But basically, they look at serum creatinine and decreases in urine output to help determine the presence and the severity of AKI. So this chart goes ahead and compares the 3 different guidelines. Rifle guidelines provide a graded definition of AKI that helps define the stage of kidney damage. AKIN and KDIGO are guidelines based on changes in serum creatinine and urine output. But basically, as you look at them, they all pretty much say the same thing. Any increase in serum creatinine greater than 0.3 milligrams per deciliter or a greater than 50% increase in 48 hours with a decrease in urine output indicates some sort of issue is going on with the kidneys. A little bit more, you can see how the stagings go through the different ones. You can see that really similar to everything. So the difference is the rifle one will go out and go all the way to loss and end stage, where AKIN and KDIGO start at the failure or stage 3. When you hit stage 3, you're going to need some sort of renal replacement therapies, just so that you're aware of that, to help kind of those kidneys recover. Each of these diagnostic criteria have their limitation. A major one is being the lack of distinguishing between the multitude of etiologies that actually lead to AKI. You know, kidney injury is rarely a standalone event, unless a person decides to drink a bunch of antifreeze. And then there's other things that actually go along with that too. It's rarely by itself. It's usually exacerbated by either existing kidney disease or existing cardiac disease. And if you are working with pediatrics, there's even more criteria for pediatric populations. For example, patients less than 18 years of age who have a decreased estimated GFR to less than 35 milliliters per minute, they actually warrant a stage 3 AKI diagnosis. I won't be talking too much about the pediatric population in AKI. This is typically an adult phenomenon that we see. So the serum creatinine and BUN are what usually these look at, but we know that both of these are affected by a variety of different things. They have, creatinine can be affected by a patient's muscle mass, age, race, gender, and can take up to like 12 hours before you see an actual rise in creatinine. BUN can be affected by medications, nutritional status, especially somebody that does a lot of high protein intake, GI bleeding, trauma, infection, and it can also take up to 24 hours to rise after the kidneys are injured. Since it's known that BUN and creatinine are suboptimal indicators for AKI, researchers have attempted to find a more accurate test, but it's still kind of needed to determine the best course of action. A lot of the tests are very expensive and just not cost effective for determining this. BUN and creatinine, and then just a physical assessment and presentation of the patients has been kind of the gold standard that we have worked with, and continues to be the best tool that we have right now in our toolbox. So the etiology, I said we'd mentioned this a little bit before. We know that it can be caused, kidney injury can caused by something happening prior to the blood getting to the kidneys, within the kidneys, or outside the kidneys. The kidneys, if you look at everything they produce, the hormones, the different systems that they will trigger, they are pretty narcissistic little organs, and they do everything in their power to protect themselves. So and they're picky too. They don't like anything being off. Otherwise, they get upset and they'll start having some injuries. So intrinsic kidney disease, or kidney disease that's actually happening within the kidney, is the true kidney disease. Pre and post acute kidney injuries are named because they're the results of other disease processes that are impacting the glomerular filtration rate that's occurring within the kidneys. So some of the causes of the or the intrinsic kidney disease is, or the pre-kidney is usually something that happened before the kidneys. So usually it's a decreased blood flow to the kidneys. So the kidneys are going to be producing angiotensin and renin to try to increase the blood pressure so that they can get blood that they want. So pre-kidney is anything that decreases that blood to the kidneys. So that could be dehydration, hemorrhaging, third space losses, big dehydration events. Some of the disease, diabetes insipidus, which of course is just causing a huge volume loss of that. So those are usually the most common, with volume depletion being the one that is going to cause the most injury to a kidney, volume depletion that leads to hypotension. So one of the things that we have been seeing here with our AKI and pre-kidney is we're seeing increased sepsis, and that can cause cardiogenic shock. It can cause all sorts of things. And if those result in a sudden drop in blood pressure, then the kidneys aren't getting perfused like they want. And then you start having trouble with the kidneys being upset. Autoregulation can also occur with any sort of the RAS system that the kidneys are trying to produce to keep the blood pressure up to them. And some drugs like NSAIDs or angiotensin converters, inhibitors, can interfere with that RAS system. So if we have meds on board, they're going to impact the kidney's ability to produce the enzymes and hormones that it wants to produce to protect itself. That will cause a problem. Another thing is you can get renal vessel occlusion, which definitely is going to cause some problems. You're going to see hepatorenal syndrome can cause different problems with the kidneys, and that's considered a pre-kidney cause of AKI. Intrinsic, once again, that's within the kidney. It's a direct insult to the kidney. So that's actually affecting the glomeruli, the tubules, the interstitium, or the vascular system within the kidney that's causing a problem. And there's a variety of different things that can cause that. The structures involved in intrinsic AKI determine the diagnosis. So acute tubular necrosis, or ATN, results from damage to the tubules. ATN is the most common cause of intrinsic AKI, and that is seen within hospitalized patients. AGN, or acute glomerular nephritis, is when the glomerulus are damaged. And then finally, acute allergic reactions can damage the interstitium, resulting in acute interstitial nephritis, or AIN. Intrinsic AKI can also result from the direct damage to the kidney vascular system, which leads to a decreased kidney perfusion that diminishes the GFR. So if you have some sort of thrombolytic or thrombotic thrombocytopenia, purpura, or TTP, or HUS, or HELP syndrome, all those can damage that renal artery and cause some occlusion. Acute tubular necrosis can result from sepsis, direct injury to the kidney, severe burn, severe muscle injury, or an extreme physical exertion. I am sorry, I cannot talk today. Nephrotoxic medications include your vancomycin, aminoglycosides, amphotericin, ID contrast, and some of the chemotherapy agents. Antifreeze, it's pretty tough on the tubules too, so if you have someone that drinks some antifreeze, you're going to get some ATN. Acute glomerular nephritis is usually a result of some sort of abnormal immune system response. So you think allergies or some sort of inflammatory response. And the same thing that happens in the rest of the body, what can also happen in the kidneys. So if you're having an acute allergic reaction, you're going to have swelling through your respiratory system that causes difficulty to breathe because all those tissues have swollen up. And the same thing is going to happen within the kidneys. Some of the more common immune system responses that you can see are lupus, ANCA, vasculitis, Goodpasture syndrome, or other forms of vasculitis. Viral or bacterial infections of the kidneys can also result in glomerular necrosis. So once again, AIN is an inflammation of the kidneys, and this can be caused by nephrotoxic medications also. So your NSAIDs, penicillin, sulfamides, cephalosporins, allopurinol, rifampin can all lead to AIN. Infections caused by streptococcal, viral, or Legionella can result in interstitial inflammation. And ANI can also result from myeloma, rhabdomyolysis, or hemolysis. So delineating between these different ones, ATN, AGN, and AIN, can be tricky due to the wide variety and shared traits of the causative agents and the overlapping symptoms that we'll see. Usually you look at the urine on these. If you have the presence of cast found in the urine, it's usually indicative of ATN. AGN symptoms may include proteinuria, hematuria, hypertension, and/or edema. AIN symptoms may include skin rash, fever, eosinophilia, and abnormal sediment in the urine. So if you think about it, AIN, same thing as what you would get with some sort of allergic reaction. Pre-kidney and intrinsic kidney AKI are certainly related. Extensive and prolonged episodes of pre-kidney causes may eventually lead to damage of the structures within the kidney. Pre-kidney AKI accounts for approximately 70% of the community-acquired AKI. Pre-kidney AKI can occur in patients with normal kidney function who have had a sudden change in their volume status from vomiting, diarrhea, or hemorrhage. So once again, any sort of interruption to the blood flow to the kidneys is going to cause problems. And that is why you see pre-kidney failure AKI is the most common that we see. Our body's autoregulatory systems attempt to correct for these volume losses and try to maintain the blood flow to the kidneys and thus maintain the glomerular filtration rate. Physical findings can help delineate pre from intrinsic AKI. Pre-kidney findings may include weight loss, orthostatic hypotension, tachycardia, poor skin turgor in patients with no other comorbid conditions. So once again, all those indicators of low volume. In patients with pre-existing cardiac disease, physical findings may be including your extended neck veins, maybe a heart sound, an extra beat in your heart sounds, some abnormal findings in your auscultation of the lungs, got rales, and then of course you'll see some peripheral edema. Intrinsic AKI physical findings may include some muscle tenderness, edema in the periorbital or sacral area and lower extremities, as well as oral and nasal ulcers, fever, and rash. So once again, when we look at oliguria, that means the person is producing less than 400 to 500 milliliters in 24 hours. Or if you want to get really down nitty gritty, it's less than 0.5 milliliters per kilogram per hour. And usually you'll see this in the first 3 to 5 hours following the recognition of septic shock. And if you do see this within that first 3 to 5 hours, it definitely has a positive association with developing stage 2 or stage 3 AKI. Now, non-oliguric just means that they may have normal output or they might have slightly decreased. It's interesting enough, we'll have patients coming in, they're really excited because they're peeing a lot. And that's good that they're peeing because they're getting rid of some of their volume, but it's not good pee. I always call it piss poor pee because it just isn't filtering. The kidneys just aren't filtering the blood like they should be. And sometimes in oliguria, you'll see them go ahead and give diuretics. And there's a limited role with diabetics. Main indication for diuretic therapy in patients with AKI is short-term treatment for volume control. And the use of diuretics to increase urine output in patients with established oliguric AKI does not shorten the duration of kidney failure or decreases the requirements for dialysis or improve survival. Just so you know, they may have urine coming out, which is great because they're helping with the volume, but the kidneys still aren't doing the job they need to be doing. Post-kidney, this should typically be one of the lesser of the 3 different types of kidney failure or kidney injury is your post. It's usually caused by an obstruction that prevents the urine from leaving the kidneys. And you'll see this with bilateral ureteral obstructions from calculi or some sort of cancer. If you have a urethral obstruction caused by benign prostatic hypertrophy, calculi or urethral stricture, that can also prevent the urine from leaving the bladder and then backing up into the kidneys. Kidney ultrasounds usually show the hydronephrosis or distended bladder in any of these patients. And if you reverse that obstruction as fast as you can, usually it takes care of the kidney damage that's occurring. Rhabdomyolysis, actually, we've seen several cases of this. Very interesting. We had one elderly gentleman, he was like 76 and had played in a tennis tournament where it was really hot. He just didn't keep himself hydrated. And when he got back to the hotel, he noticed that his urine looked like Coca-Cola and he just didn't recover very fast because he's an elderly man and with some underlying comorbid conditions. And when he returned home, he went to see his doctor and yeah, sure enough, he was in AKI and he needed about 3 weeks of dialysis just to kind of get his kidneys up and running again. So these special clinical scenarios such as rhabdo, drug-induced issues like, especially from the IV contrast, TTP, hemolysis, elevated liver enzymes, low platelets, and other non-kidney organ dysfunction can also cause AKI. And interesting enough, with COVID-19, when it first came out in 2020, if you survive that and don't have PTSD from it, bless you, because that was just a horrid time. And they weren't quite sure why COVID-19 was causing the acute kidney injury like it was, but it was definitely a grim finding. And I think we only had one person that was COVID positive that developed AKI that actually survived it. It was pretty gnarly. But here recently, since that great big peak in 20 and 21, we haven't seen AKI from COVID-19. The hospitalizations from COVID-19 are definitely down. So knock on wood, and I almost hate to say it out loud. Well, I won't. I won't say it out loud, but you know what I'm thinking. I don't want to jinx us, but COVID-19 definitely is here, and we're seeing an outbreak of it, but we don't see the AKI with it like we used to. So once we talked about rhabdo, it's a breakdown and necrosis of the damaged skeletal muscles that release their cell contents, such as the myoglobin, into the bloodstream. And these products can obstruct or inflame the tubules, resulting in AKI. And some of the traumatic causes of rhabdo include crush injuries from auto accidents. I mean, anything that is really damaging the muscles severely, that is causing them to release all their contents. Electrical shock, venomous snakes, if they got a bite and then they get necrosis around that bite, can also cause rhabdo. Some non-traumatic causes include the use of alcohol or illegal drugs such as heroin, cocaine, or amphetamines, extreme muscle strain from exercise, high doses of certain medications, your statins and your antipsychotics. In fact, we just had a patient now that we've been dialyzing this week that had a rhabdo from statins. Sometimes hypothermia, you think about that. If you really heat up your muscles, you're going to damage those muscle cells and they're going to go ahead and release their substances. Seizures, prolonged seizures where they're straining the muscles. Any sort of disease of the muscle, viral infection, or sepsis can all lead to rhabdo. And as I said, you know, the color of the urine is dark, Coca-Cola colored, and pH is going to be acidotic. There's definitely going to be some blood in there. There'll be some sediments in the urine also, and then the sodium is going to be concentrated in the urine. Different medications that have toxic effects on the kidneys, your NSAIDs, aminoglycosides, antibiotics, contrast agents, and ACEIs. Usually are the most common cause of AKI in hospitalized patients. Our hospitalists, when they notice that creatinine creeping up, especially by 50% or 1.5 times, they are looking at all these nephrotoxic drugs and removing them from the patients, so we're no longer giving them. The kidney tubules are especially vulnerable since they are responsible for concentrating and reabsorption of the glomerular filtration. So IV contrast-induced AKI is actually one of the most common causes of AKI within the hospitalized patient population. And so if we have somebody whose kidneys aren't very happy, they're definitely going to be looking at whether or not they need to be doing contrast when they do CTs and stuff. Contrast-induced AKI is associated with morbidity and mortality and may not be reversible and often leads to chronic kidney disease. They have changed their contrasts now, so they aren't quite as renal toxic, but it's definitely something that you are concerned with in people that have comorbid conditions and cardiac issues. The actual pathophysiology of it, though, is really not well understood, and the best preventable measure is to avoid unnecessary contrast administration at all. Some of the blood dyscrasias that can cause AKI, the TTP, and you think about it, you have a bunch of destroyed red blood cells floating around, or you know, products of the blood floating around that the kidneys are going to be trying to filter out, and they actually, those little microthrombi actually occlude the terminal ends of the arterioles and the capillaries within the kidneys. And patients who develop AKI are described as having hemolytic uremic syndrome, or HUS, if they have it from TTP. Hemolysis with elevated enzymes and low platelets is also a potentially fatal syndrome in pregnant women associated with preeclampsia. And that's another thing that's real interesting. We've seen more preeclampsia lately here in the last couple of months with our pregnant women. It's interesting. In fact, they've asked me to give a talk in our Women's and Children's Center about the kidneys in pregnancy. Very, very interesting. AKI during pregnancy is relatively rare, thank goodness, because usually if you deliver the woman, it takes care of the AKI or the hypertension that's causing a problem. So like usually a prompt intervention with the pregnant population to deliver the baby is what will take care of that, prevent progression to AKI. Talked a little bit about COVID-19 and the role, excuse me. I'll back up here. Sorry. The role of AKI in the presence of multi-organ dysfunction really is a chicken or an egg sort of scenario. It's hard to say what came first. We know that cardiac and respiratory issues that affect the blood and the oxygenation of the blood going to the kidneys are going to cause problems. But then we know if the kidneys are having problems, they're going to cause problems with cardiac and respiratory. So certainly organ dysfunction can lead to physiology that is detrimental to the kidneys. Recent evidence suggests that AKI is an indicator of illness severity, and it can be a significant player in the earlier development of multi-organ dysfunction. As I said, AKI is rarely an isolated event. It's either caused by other organ dysfunction or will lead to organ injury through pro-inflammatory mechanisms. Poor cardiac functioning decreases the blood flow to the kidneys, which can decrease GFR, causing increased volume status. Increased volume status leads to respiratory problems and all sorts of things. And then, pulmonary congestion, the heart has to work harder. So it really is, what comes first in these sort of things. If they all happen at once, then it really is a bit of a problem. So the question is, does kidney failure result in cardiac dysfunction and then eventually pulmonary dysfunction, or do the lungs and heart start the whole downward spiral with AKI? Talked a little bit about COVID-19. As I said before, it was pretty awful. They weren't quite sure why COVID-19, the initial variants of it, were so detrimental to the kidneys. It definitely appeared to be an intrinsic problem. There was some inflammatory, so interstitial disease with it. There was tubular disease. It was definitely a problem. They were thinking that the virus was actually doing direct damage to the virus, to the kidney cells. You had the hypoxia, which certainly causes that cytokinetic storm that increases the coagulability of the patient, which increases blood clots to the kidneys. I mean, there was a lot of different things that were happening during that initial COVID-19 outbreaks that were causing some real issues with the kidneys. But as I said, it seems like the later variants, the ones that we're seeing now, don't seem to be quite as egregious to the kidneys. So what do? You have to assess for the risk or presence of AKI. So you definitely need to get a decent past medical history on this person. You want to get some sort of baseline lab on them. Some of the things you ask yourself: did this patient have any type of intervention or disease process that resulted in hypovolemia? Are they receiving kidney toxic medications? Have they received IV contrast? And all these things you need to be looking at. So you're looking at, did they have surgery? Did they have sepsis? Did they have some anorexia that led to poor or no oral intake? Did they have a lot of fluid loss from the GI tract? Did they have an MI? Did they have any sort of anaphylactic reaction, abdominal trauma, or exposure to consecutive days of hot, humid weather that resulted in dehydration? So that initial physical assessment findings that include the risk for AKI include dry mucous membranes you might see, poor skin turgor, reduced JVD, hypotension, decreased urine output, and/or weight loss. Some of the lab findings you're going to see, of course, going to be increased serum creatinine and BUN, some increased urine osmolality and specific gravity, and decrease in urine sodium and urea. As a kidney injury increases, opposite symptoms may develop. I mean, these include fluid volume overload, resulting in hypertension, excuse me, and then also weight gain and increased jugular vein distension. So all of these things you kind of look at to begin with, but you want to get that baseline assessment and get those baseline labs to see how those increase or decrease. Treatment of AKI always focuses on what is causing it, and we want to alleviate whatever causative factor that is, and we want to get everything back to those kidneys so those kidneys are perfusion like they want to. So look at the patient's medication and discontinue anything that are nephrotoxic. Diagnostic imaging that requires contrast should be avoided at all possible. Hydration needs to occur to achieve that normal fluid volume, and you can do that with fluid volume boluses, or you can just do it with a maintenance. Nursing interventions include accurate intake and output, daily weights, adhering to infection control measures, monitoring volume status for physical assessment and vital signs, as well as administering medications and fluids as prescribed, monitoring lab values, and providing patient and family education. And anybody that hears kidney disease or kidney failure, of course, this is a terribly scary time for them. So need a lot of education and interventions and empathy and loving care to help people work their way through this. So daily weights, I just have my own personal preference on it. A lot of the times we see these bed weights, and I have yet to find a bed that I think weighs appropriately. So if you can get the person up to a standing scale, that is even better. Bed weights, if they're really controlled well, can be helpful, but for the most part, I don't find a bed weight too helpful other than showing trends. So it's just to know that. It's also, when you have these people with AKI, the last thing you want to do is to get any sort of infection. So it really is a nurse's responsibility to prevent those hospital-acquired infections and adverse events. You want to make sure that the Foley is draining like it's supposed to be. The Foley catheter bag is underneath the bladder where it needs to be. You want to avoid kinking in that. So you certainly don't want have any post-renal sort of process going on that's going to damage those kidneys. Any additional nursing interventions that you want to do is prevention of any sort of secondary issues by encouraging turning, coughing, deep breathing to promote that pulmonary functioning and pulmonary hygiene. You want to make sure your skin's taken care of, monitor nutritional status, and assure that there's a safe environment for this person to be in. So as we said, these are all known as the nursing actions, or collaboratively known as the nursing process of care. While care of every patient should be an interdisciplinary responsibility, we know that it is the nurse with whom the patient interacts the most. And we also know that our process of care is not limited to specific medical orders for specific diagnoses. It's our knowledge as a nurse and our holistic experience that leads us to use our process to critically think about not only what we are doing, but what else needs to be done to help this patient with acute kidney injury, so that we can help restore them to the best quality and quantity of life. So again, patient education is really important. Here we have that ANNA publications, Scope and Standard of Practice. This is an excellent resource for you. It has all the different things you need for the nursing process to help patients with AKI. Another big thing that we really need to look at is advanced care planning with potential therapy. So as AKI progresses, the person may need renal replacement therapy or kidney replacement therapy. And prior to administration any KRT, it's important to determine if the patient and family wishes to continue with aggressive care. So one of our patients with AKI, quality of life was very poor. Initially, thought, yeah, maybe I could get a little bit better with a little bit of dialysis. Realized that wasn't the case. We dialyzed her a couple times and then realized that quality of life was going to be quite poor. And then you have to support the patient and families decision process of what he or she wants or does not want to do next. So, palliative care consult is really, really important with these people. You need to do some advanced care planning with them. It's hard to do urgent advanced care planning with anybody in the presence of acute injury or acute conditions. So sometimes it'll fall upon the family to make those decisions. And then that is a hard discussion to have with family, because you have to, if the patient's unable to articulate what he or she wants, then guiding the family through that is important. And that's where palliative care really does come into play. If the person does wish to do kidney replacement therapy, the following slides will kind of go over what our options are for that. So indications for kidney replacement therapy, like we need to do it now or 5 minutes ago, is of course hyperkalemia, any metabolic acidosis, volume overload, any uremic pericarditis, inuria or severe oliguria, pronounced azotemia, encephalopathy, or infection. Those are kind of, if you start seeing uremic peritonitis or encephalopathy, you're probably pretty far into the AKI process and probably should have caught it a little bit sooner. Diogo recommends initiating renal replacement therapy at stage 2, or if the serum creatinine is increased by 2 to 2.9 times the baseline. Now, the type of renal replacement therapy, or KRT, utilized depends on the severity of the AKI. Urgent start peritoneal dialysis is usually not appropriate for patients with life-threatening electrolyte imbalances or fluid overload, just because of how slow PD responds to the normalization of those electrolyte imbalances. And we know that hemodialysis is fast. So if you have somebody that needs KRT and renal replacement therapy, you need to have an access in them. For urgent start hemodialysis and continuous kidney replacement therapy, the access is usually an uncuffed central venous catheter in patients whose kidney function is expected to return to normal within 7 to 10 days. If the period of kidney recovery is expected to extend beyond that 7 to 10 days, then you should put a tunnel catheter in. The catheters are double lumen. They're always placed in a vein, either the internal jugular or the femoral vein. Try to avoid the femoral vein just because it is kind of a nasty spot to have a catheter that's going into a large vein. You can do it in a bed-bound patient, but it really should not remain in place more than 3 days. If you have a stable patient with AKI that is just kind of stuck in a phase but just needs a little bit of help from kidneys, you can consider PD. But that problem with that is you have to place the catheter, the PD catheter, and then you need to do urgent start PDs, which is its own little joyful event to try to undertake. The different types of hemodialysis we can do. So for the most part, if you have somebody with AKI, hemodialysis is what you're going to do. And there's different ones you can do. You can do intermittent hemodialysis. You can do SLED. You get CKRT. You get SCUF, CVVH, CVVHD, HVHF, and there's a variety of different types you can do. And it all kind of just looks at how you're moving that fluid around and how you're moving those electrolytes around it. Certainly short daily intermittent treatments work well. You can do continuous treatments. It can last up for 24 hours. Those work well. And really the therapy options that are available depend on the patient and also what the practitioners are used to doing. Like, we don't do CRRT here at the hospital because we wouldn't do it enough to keep up on the different machines and the different programs of it. So we'll do intermittent hemodialysis, and we've had actually really good success in dealing with people with AKI with intermittent hemodialysis. So if you do intermittent, you want to do short daily treatments, 3 to 5 hours. It's highly effective in solute and fluid removal, but can result in rapid removal of both. It can lead to further hemodynamic instability in critically ill patients. So when you do intermittent hemodialysis, you got to do it kind of slow and carefully, because it can cause dialysis disequilibrium syndrome in patients with pre-existing cerebral edema or severe uremia. That BUN is greater than 175. You have to be kind of careful. You want to make sure that your blood flow is slow and your dialysate flow is low on that. So the dialysis disequilibrium syndrome, you can see a range of neurological symptoms: headache, nausea, blurred vision, restlessness, somnolence, confusion, disorientation, and anomia. So the two main approaches that I've said before to limit the risk of that is slow removal of solutes during IHD, watching your sodium concentration. So you look at the person's serum sodium, and if they got a serum sodium at 130, you don't want to set the machine at 140. That's for sure. You want to get it as close to what their serum sodium is, so that you're not having a rapid change in serum sodium. So you can decrease that solute removal by slowing down your dialysate and blood flow, and then shortening your sessions. So typical initiation of the hemodialysis prescription: you want to do 2 hours treatment with a blood flow of like 150 to 200, and the dialysate flow twice the blood flow rate. So usually we would run dialysate flow, 300 to 400 or 300. Yeah, 300 is about what we normally run. And the ultrafiltration rate is the amount of fluid that's removed per hour. You want that to be either no fluid removal or as much as needed to help control the fluid volume status. Most machines now have crit lines on them. They're super helpful when you're removing fluid, so you can just see how well the patient is tolerating it and how well their refill is occurring. Remember, once again, that fluid removal should not exceed 13 milliliters per kilogram per hour, so that you can prevent that cardiac stunning. Read an interesting article on that, where they were doing echoes on people at the beginning of dialysis where they had that greater than 15 milliliters per kilogram, and 13 milliliters per kilogram, and you could actually watch the heart look like it was having an MI. Very interesting. So your sodium levels could start up high, or you can model them down, or you can just leave them steady throughout the treatment, but they should be 5 to 10 milliequivalents above the patient's serum level. It's carried out daily and can be increased by 30 minutes per treatment. Blood flow rate can also be increased by 50 milliliters per minute, and the dialysis flow rate can increase to twice the blood flow rate. So, the first treatment you might do 2 hours, next do 2.5, 3, 3.5, 4. And then you can increase your blood flow rate and your dialysate flow rate as you increase your time. Intermittent hemodialysis, some of the advantages of it: short duration, doesn't require the anticoagulation that CRRT does. It's really efficient, super good for removing some of your drugs that are causing some renal toxicity, and it is flexible. Disadvantages is you train nurses there to do it, and you have to have the infrastructure to provide the purified water to the machine. So portable ROs, or if you have a Tableau, you got the built-in the water system in that machine. So it's that can be a problem getting water to your ICUs if you don't have enough portable water systems. IHD is contraindicated in any patient with traumatic brain injury, just because of that disequilibrium syndrome, but is usually the choice. IHD is usually the choice for any sort of lithium toxicity, alcohol toxicity, or salicylate overdoses. SLED is low efficient dialysis. It's a modification of intermittent dialysis. Treatments can be performed using a variety of combination of frequent treatment times, blood flow rates, dialysate solutions, and ultrafiltration rates. SLED extends the treatment time and go up to 12 hours. which decreases the rate of both solute clearance and ultrafiltration per hour. So slow and long is what SLED is. Advantages of it include ease of use, flexibility. Usually have stable hemodynamics in these patients because you're not doing a lot of shifting. It's pretty slow. The body can refill to meet the needs of the vascular bed. You don't need as much anticoagulant requirements. You can have some mobility of the patient during the treatments. Some people and some hospitals and practitioners do prefer SLED over CKRT just because of the financial reason. The CKRT requires a different machine, and SLED, which can be done using a typical dialysis machine. Sometimes with SLED, you have the dialysis nurse that's actually monitoring that, where CRRT, you could train ICU nurses to run those. Disadvantages of SLED include the need for a trained personnel, so you have to have a dialysis nurse present. You have to have the infrastructure ready to provide that purified water to the machine, just like with intermittent hemodialysis. You can get some hypophosphatemia and hypothermia with it, and there's actually no contradictions to SLED. So if you think about when we were doing the next stages, that's one of the things we were problem because they were basically doing SLED, slow dialysis, and we were seeing hypophosphatemia in those patients. And it's, you know, it's noteworthy that you could say, well, why don't we have the ICU nurses run these patients? But the dialysis nurse definitely presents more expertise in troubleshooting and perhaps better patient monitoring over an ICU nurse. And there's some clinical studies out there that show that there's really no safety advantages of CRRT over SLED. Just for a little tidbit for your toolbox. Continuous kidney replacement therapy, or CKRT, is another option to treat hospitalized patients with AKI. It mimics the function of the kidneys and is intended to be applied continuously and gently for 24 hours or longer. There's different modalities for it. There's slow continuous ultrafiltration, continuous venous hemofiltration, continuous venous hemodialysis, and sometimes referred to as continuous hemodialysis or high volume hemofiltration. So whole gob of alphabet soup with these different types of modality. So venous means the blood is pulled from a vein through an artificial kidney or fiber and then returned to the same vein via a double lumen catheter. Historically, continuous CAVH, CAVHD, or CAVHDF were used, but since these require both arterial and venous circuits, they've kind of fallen out of favor and are rarely used today. So basically what you see is that the venous ultrafiltration is what you see. Scuff is used to remove fluid only, so slow continuous ultrafiltration. Solute clearance is minimal due to the nature of the treatment and should not be used in patients who are uremic or hyperkalemic. They're not going to do anything to affect the electrolyte imbalances of somebody that has acute kidney injury. So this is just for fluid volume status. Treatment's usually a typical 24 hours with a goal to achieve volume control of patients with severe diuretic resistant volume overload. And UF rates are typical less than 10 milliliters per minute, with the typical fluid removal up to 8 liters of fluid in 24 hours. Two types of hemofiltration: continuous venous hemofiltration, CVVH, and HVHF. CVVH is used to achieve solute clearance and volume control. Any ultrafiltration or fluid removal is replaced with IV crystalloid solutions. Solute removal is entirely by convection, and dialysis is not used, and CVVH uses hydrostatic pressure to induce filtration across the hemodialysis filter. And the UF rate can be as high as 20 to 25 milliliters per kilogram per hour with CVVH. HVHF's goal is to increase the blood purification, remove cytokines and components of sepsis, excuse me. It can also be used to remove water-soluble free toxin drugs such as lithium or sodium valproate. HVHF uses from 6 to 10 liters of replacement fluid and requires dose attention to patient's fluid status. So we'll use these guys to clean the blood and remove the toxins. And sometimes you just don't see the UF with these, so you don't get someone with volume status issues may not be a real good candidate for this. Advantages of CVVHD removes solutes by diffusion, utilizing dialysate to do so, and ultrafiltration rates can only be 2 to 8 milliliters per minute, and no replacement fluid is needed. So that's for CVVHD. Advantages of CKRT or CRRT includes increased hemodynamic stability, less cardiovascular impact because we're doing slow and long on these, so we're not stunning that heart that we can in faster fluid removal. Increased potential for kidney function recovery. It's just a gentler thing on the kidneys. It doesn't give them other things to be worried about other than just healing themselves. Trained ICU staff can monitor the treatments. And last but not least, it provides superior solute removal and volume control while simultaneously allowing the administration of parenteral nutritional fluids. So if you have somebody that needs to have some IDPN, you can do it at the same time you're doing CKRT or CRRT. Disadvantages include the frequent interruption in therapy due to system issues, anticoagulation needs to prevent the system clotting. People need to be on bed rest. There's a risk of hypothermia and hyperkalemia. It's also very expensive, and it is contradicted in any patient that is mobile or is agitated. They have to be pretty well tied down to do CRRT. Talked a little bit about peritoneal dialysis. It can be used in AKI, and this actually modality is overlooked. If you have somebody with kind of steady AKI, which doesn't happen very often, you can contemplate PD, especially if they have an underlying CKD and they're kind of close to needing dialysis. You could put a PD catheter in them, get them through the AKI episode, and then if their CKD has progressed, then you can continue on that home therapy. So prior to the development of the dialysis, central venous catheters, and CRRT in the 1990s, actually PD was the routine treatment for AKI and is still used in developing countries for that diagnosis. The lack of use in high resource countries such as ourselves has led to a scarcity of research supporting its use. There was a little bit more scrutiny into PD with the COVID, and because we had such a shortage of supplies to actually deal with the COVID outfall, they were looking at doing PD a little bit more. Also with the COVID-19, with the hypercoagulability that they were having, PD was an option because it was something that we wouldn't have to worry about the system clotting up as we're trying to dialyze them. So as we know, PD doesn't require a system anticoagulation, and it doesn't have circuits that can clot. Another advantage of PD over HD is that the cycler can be placed outside a patient's room by using extension tubing to connect a patient, thus limiting staff exposure to COVID-19. So that's one of the things they were looking at is decreasing the amount of time a staff member had to be in the room with somebody that was COVID-19, the initial bouts of it. Acute peritoneal dialysis can happen, and it actually is a pretty slick process. You can put a catheter in, and then, typically you want at least a 2-week healing period so that they don't leak in around that tunnel or leak through that catheter. But you can start PD as soon as 24 hours, 48 hours after the patient has had the catheter placed. You just have to keep them supine. And then you want to keep the dwell times low and the fill volumes low so that you don't increase that interabdominal pressure to cause any sort of leaking around that catheter. The process of fill, dwell, and drain is referred to as a cycle on exchange. So you want to make sure that the dwell times are low, their fill volume is low, and their drain volume should equal pretty close to their fill volume. You don't want to, say you put 1,500 in and you only get a liter out. You might contemplate not putting 1,500 milliliters in the second time, so you don't know if that 500 stayed in there or if they absorbed it. So there is a little bit of monitoring involved with it. The glucose concentration of the PD fluid is going to help determine the ultrafiltration. The higher the glucose concentration, the more ultrafiltration you get. Manual exchanges can be time consuming and involve a educated staff member to actually do the exchanges. So usually you don't do CAPD. You put them on a cycler for 8 hours, lay them flat in a bed. If they need to get up and go to the bathroom, you drain them before you let them go up to the bathroom. You just want to do everything in your power to prevent any sort of increased abdominal pressure on them. But it works pretty good. So, and you can put them on for 8 hours and just let them lay there and watch TV if they feel up to it, or visit with family. And then you have to get up, you just drain them and let them get up to the bathroom. So it works pretty well. The advantages of PD is it's easy to use. We used to have unlimited resources, but definitely having some issues with the Baxter company and factories in North Carolina because of the hurricane that went through. So typically it's low cost, usually has good availability. There is some, it is fairly efficient at removing fluid and solute. You can, there's debate on whether or not it will shorten the episode of AKI over hemodialysis. It's always hard to know that. I mean, they've often talked about how PD will help preserve residual renal function. 6 of one, half does another. Hard to say if that really is true. So some of the disadvantages are just lack of knowledge over the modality. Not sure the prescription parameters. You do definitely have a delayed in fluid and solute removal just because it isn't as efficient. Can have the risk of peritonitis with it, so that's always a problem. If you have somebody with AKI and then you give them peritonitis on top of it, that's kind of a bad thing. There's not much research out there to support the use of PD and AKI. If you have somebody that has some severe electrolyte disturbances that need to be resolved fairly quickly, PD is not your answer for you. You are going to be disrupting the abdominal cavity. You are going to be pushing on their diaphragm that may make them feel full and have some respiratory issues with that. It's certainly, if you have somebody with an abdominal surgery or anything that has interrupted that peritoneal lining, they're not a candidate for PD. So if you have any other questions about PD, the ISPD, or the International Society of Peritoneal Dialysis, has developed prescriptions, guidelines for the use of PD to treat AKI patients. So that's always kind of my go-to Bible for PD stuff is the ISPD. Oh, 1:30, we're getting there. So we've talked about the morbidity and mortality of AKI. If you have recurrent AKI, definitely is a problem. More frequently you have it, the sicker you're going to get with each one. Progression to CKD, interesting enough with the studies that were showing the patients that had AKI during COVID, if they survived COVID, they did not have a progression to CKD. They were worried that they were going to, but they didn't. Definitely less progression or speed of progression than people that have the comorbid conditions that get the AKI. Some of the other problems that you can have, I mean, definitely have people that die from AKI. If you already have somebody that's in ICU on a ventilator and then develop AKI, the prognosis is really, really grim on that. So there's also unfortunately some real disparities. This is a real troubling trend. That is the disparity between Black and white patients. Per the US RDS annual report, relatives to white patients and the adjusted rate of hospitalizations with AKI was over 75% higher in Black patients, and the adjusted rate of hospitalizations with AKI requiring dialysis was over 110% higher in Black patients. So following a live discharge from hospitalization with AKI, Black patients were more likely to experience a reoccurrence of hospitalization with AKI than white patients. So very troubling, so that we know that there's definitely disparity within our healthcare system. And this is just really some grim statistics that show that. I mean, Blacks even have a higher incident of recurrence by year 2, and their incident rate is 40.9% of recurrence within 2 years. And then they also have, if they're diabetic, they definitely have a higher incident rate than over the white partners. We are seeing an increase in hospitalizations related to AKI. I've even said that we've seen it this year, which has been really, really interesting. So that's something that is occurring. So you know that you're in there, you're going to be seeing some AKI. Clinical outcomes. Among older Medicare beneficiaries who initiated outpatient dialysis for AKI in 2020, at 6 months, 31% of them had recovered kidney function. 2.4 remained on dialysis with AKI, and 47% had progressed to ESRD. So if you have some comorbid conditions, and so Medicare, they're going to be elderly with comorbid conditions, the chances of progressing to ESRD with an AKI incident is definitely higher. So, and then one of the recommendations in July of this year was that allow AKI patients to dialyze at home, which is certainly a good option because these people may not require 3 times a week dialysis. And if we can get them home, they're less exposed to any sort of the things that they can get within the dialysis unit. It would help them mentally and emotionally, possibly to dialyze at home. So don't overlook the possibility of doing home therapy on these people if it looks like it's going to be an extended process. So in summary, AKI, you'll see it in 10 to 15% of inpatients and 50% in ICU. So the sicker they are, the more chance they have of getting AKI. Anybody that works within the hospital, acute care setting, is going to encounter AKI. There is new options. One of them is home therapy, so that definitely shouldn't be overlooked. If you have early recognition and intervention, you have improved outcomes of that, and more extensive information on causes, staging, and treatment options and outcomes for AKI can be found at these different organizations. So hopefully this module has helped you become more aware of the risk factors associated with kidney injury and the treatment options available to protect the kidneys. The most important intervention is early recognition and alleviation of causative factors that lead to kidney injury, thus preventing AKI from advancing to a stage where the kidney replacement therapy is needed. More detail and information on causes, staging, and treatment options can be found at those 2 organizations that I just talked about. Just one last thing to keep in mind, the synergy between acute kidney injury and chronic kidney disease, one frequently leads to another. And that includes our my talk today. Thank you. For more information on chronic kidney disease and kidney replacement therapies for both adults and children, look for our other modules. They are just an excellent resource. Thank you. Thank you. Thank you for the care you give to all our patients. And just want to have sure to check out the handouts. It can be downloaded in an online library. You can see the slides, the narrative. Want to thank the authors for the different modules. And once again, thank you, Leslie, for being the carrot and stick behind these modules. It's been absolutely amazing working with her and her dedication to the revision of this. And I know that my articulation and wonderful voice just weren't up to speed when it came to Leslie. So once again, thanks so much for Leslie. Here are the references. And that's it. Thank you so much, everybody.